Okay, welcome everyone for our first journal club of this year, and we've bucked the trend and moved it to a Tuesday morning, so I think it may have confused a few of our national and international listeners, but we would very much like to welcome Professor David Patrick, who is a Professor of Population and Public Health. He's actually in Australia to learn about how we do antimicrobial stewardship in Australia. And he's had a very busy program meeting people all over the place, and his particular focus is on community antimicrobial stewardship. So I'll welcome David to the lectern.
Well, good morning to everyone in the room and those of you elsewhere in the country. I'm very grateful to be invited here to NCAS and the Doherty. We've had a chance to interact with a lot of people, and this is a chance to do just a little bit more in that direction. I want to let you know, first of all, that I don't have conflicts of interest through industry relationships. Our funding is through institutes similar to your NHMRC. And the program I'll be talking about partway through the talk is funded by the British Columbia Ministry of Health along the way. So we're here really to compare notes. And we can do this on many different levels. We could do this by checking out our prime ministers. You've got Turnbull here, who's looking pretty dapper on the cover of GQ. And we can say the same thing about our prime minister. Justin Trudeau's done well, and both of them have had their names mangled by the White House in the last month or so. So we have that in common. But more importantly, the reason we chose Australia as a case study in stewardship is that you are a similar federal model to us. You've got a lot of constitutional responsibility for health vested in the states, as we do in the provinces, but you have a national responsibility to WHO and the world to show that you're pulling together. And in some ways, you're doing that better than we are, and that's one of the things we're looking to learn about. So I'm talking to a bunch of people here who are thinking infectious diseases all the time, but it's important sometimes in public health to say, why is this also a public health problem? And you're familiar with the mortality issues. You're familiar with the European statistics of about 25,000 deaths a year, similar thing with the US. So I don't know how you do it in Oz, but in Canada we divide by 10. And we say, okay, we've probably got 2,000 to 3,000 deaths there if we don't have our own statistics, but we're working on that. But I'm really interested in the morbidity. The morbidity, and I can measure it by taking a look at office visits and so forth, is in the order of tens of thousands of community illness episodes for UTI, skin and soft tissue infection, where they're now harder to treat because of the rapid emergence of resistant organisms over the last 15 years. So it could be that I'm seeing CA-MRSA, most of the time not requiring antibiotics, but when it does, it's more of a problem. So we're paying attention to this, not just because a British chief medical health officer has said that we should, and I've learned the term POM since I've been here, and I'm not going to apply that to Dame Sally because she really is a great person. Antibiotic resistance in the public health paradigm, though, when we're dealing with this, it's important to remember to my public health colleagues that the risk for this is not individually determined. That's why it's not just a clinical issue. Resistance is selected for in one person, the pathogen is passed on to others, and it may be generations of transmission before we see illness in another person. Further, as you found, anybody in stewardship is aware, antibiotic use is socially determined. It's socially determined by the culture of prescribing, but also by the expectations of the patients and everything else along the way. And that means that health promotion, where we're often reminded that just educating people isn't enough, that we've got to provide elements of reinforcement to make behaviors more likely, is that much more important. From my perspective, a lot of the action is in the community. Hospitals are special places because of the intensity of use and the likelihood of natural selection in that environment. But 80–85% of human antimicrobial use is in the community, and so it's a pretty important place to look. And of course, when you begin to expand things to agriculture, effluents, sewage, that sort of thing, environmental determinants are very much at play. So I'm not going to talk about this diagram just to show its relative complexity. You know, you've got the yellow circle there talking about all human use. You've got the sort of orangey, pinky circle there talking about animal use. And they're all connected by a lot of different routes. And this is often put up by my colleagues in the Public Health Agency of Canada, and we've coined it the confusogram, but it really is just an illustration of the complexity of the One Health full ecological perspective that we need to take on antimicrobial resistance, a perspective that is nice to see built into the constitution of NCAS. So where might this go? You always talk about this in hospitals in terms of the safety of healthcare, surgery, transplants, and that kind of thing. I'm also conscious that this can increase the burden of illness from infectious diseases in the community, and that poor control of infections hurts economies. This, of course, clobbered West Africa with Ebola in recent years. But you remember, I'm from a country where one of our major cities, Toronto, was almost shut down from SARS for a couple of months. That cost billions, and that was just a little bit of a failure of hospital infection control. That wasn't even a big community outbreak. So we're very conscious of the need to control this for human well-being and cost. I don't have to talk to a group at the Doherty about natural selection, but it is interesting when you're talking to the public that you have to remind them that it's sort of a two-step thing. You've got a chaos phenomenon of exchange of genetic material or perhaps mutation, and that's completely random. We can't really control that. And then you've got, as Dawkins would put it, the entirely non-random process of natural selection coming through. So much so that although we can't exactly quantify what a given level of antimicrobial use does to natural selection, we can think of it as a force pressing things along. So whether we need antibiotics for therapeutics or whether we don't and we're using them inappropriately, this natural selection is driven by our use in people, in pets, in food production, and so forth. And then the chaos is something that we all try to control. Australia and Canada have a big problem with importation from areas of higher endemicity of antibiotic resistance determinants. And whenever you get something new in a population, it's going to spread more rapidly in a dense population, whether that's a chicken coop or a densely packed hospital ward or a dense community. And we try and contain that in the community with hygiene, sanitation, as you do in facilities with hospital infection control. So turning around to the response globally, WHO has been fairly prescriptive about what nation states should do, and certainly having an action plan is one of those things. On the right, there's the global action plan from WHO. There's a version here in the middle from the US, and there's your own recently coined national action plan on the left. So what I'm going to tell you about first is the saga of getting our act together in Canada. Over here you'll see a Mountie, and I don't know if you know much about the history of the Canadian prairies, but of course the mounted police went out there to save it from American whiskey salesmen, and Fort Calgary was actually established by the Mounties. To the right of the Mountie is John Conley. He's another Calgarian, and he's a senior scholar in infectious disease in Canada. And John's been giving me the long history of how hard we've been trying to pull this off. So in the 80s and 90s, there was long-standing interest in getting our act together on resistance. There was, in fact, a document put together in 97 which laid out a really good strategy for controlling antibiotic resistance, but this never got too much political traction. Many areas were never funded. The committee that put it together was actually disbanded in 2003, and this left us very much behind the eight ball. But that was on a national scale. And the nice thing about federations is that sometimes you learn from what people are doing in different parts, and you can all get together and do things. So if we take a look at what was going on around the country at the provincial level, Quebec, as you may remember, was clobbered by Clostridium difficile mortality in the mid-2000s when a new strain hit its hospitals. And in response, they developed some very stringent antimicrobial guidelines, both for hospitals and communities, and that put them ahead of the curve in terms of reducing use. You go across the Ottawa River into Ontario, and down in Toronto, our colleagues Andrew Morris and others began in a small cluster of Toronto hospitals associated with U of T, developing hospital stewardship, and that's now moved to a province-wide strategy, which is probably our most advanced in Canada at the moment on hospital stewardship. Moving further west to Alberta and British Columbia, I'll be telling you about a program of community stewardship that we in fact share across the two provincial jurisdictions. And then across the country, the Canadian Medical Association is beginning to turn to this as part of the Choosing Wisely campaigns that physicians are doing. So there's not been a complete vacuum, but we're trying to get our act together nationally. In 2014, I had the pleasure of working with a group of colleagues on a grant from the National Collaborating Centre of Infectious Diseases, which was basically giving a report card on surveillance for antimicrobial use and antimicrobial resistance in Canada. And basically in 2 slides, this is what we found. The resistance surveillance at the hospital level was focused very much on sort of specific hospital infections, so MRSA, VRE, CDAD, but there was no sort of widespread tracking of hospital antibiograms going on so that you could take a look at the universe of threats happening. In the community, across most of the provinces, there really wasn't much in the way of representative surveillance in terms of community isolates. A couple of places had that going. In agriculture, we'd had a program that was focusing on sort of farm to fork with salmonella, and it was recently expanded to deal with Campylobacter and a few other things. But once again, a few selected organisms, and you can't always tell if you may be looking in the wrong place at the wrong time. Oh, I got something on the screen here. Just need to. Thank you very much. I think I have to kill this, don't I?
No. Oh.
It was this thing that popped up, and you moved it over there. But this thing, I think, is responsible for slowing us up. Try to do that now. Okay. And then, of course, veterinary medicine, companion animal veterinary medicine was more or less a black hole. Agriculture, very much like you, the best we could do is come up with gross mass of antibiotics that were being imported into the country for that purpose. So a lot of work had to be done. On antimicrobial, agriculture, very little. Antimicrobial use data, the Public Health Agency of Canada had been purchasing data from IMS Health, which probably has data on Australia as well. And they synthesized some fairly broad reports that allowed you to sort of see what was going on province by province. You can see here Quebec with the lowest overall utilization, and the colors here can tell you which classes of antimicrobials are being used. And BC out here was the second lowest. And because we were more aggressive with generic pricing and drug selection, we were paying less per capita than anyone else. But that was just the beginning of what was going on there. In the hospitals, there really wasn't much data on utilization, and we had very few useful data from agriculture or companion animal practice. So to put it this way, I was skiing in January, and these kids come up with a ski school with a penny on them, and I met Raph from Adelaide. He's probably 5 or 6, and he was interested in bears. He hadn't seen any bears, was wondering. So we got into this conversation about what would happen if a saltwater croc met a bear, who was going to come out on top. And I sort of concluded after a while that if it was in deep water, the bear was in trouble, advantage croc. And that's probably very much the case when we take a look at where we were at in 2014. And if you like the pop lyric sort of things, because obviously we've been sharing a lot of pop lyrics back and forth between countries, there was a risk that we were on a highway to hell and that our beds were burning. It really was a long way to the top if we want to rock and roll when it came to stewardship. So no more jive talking. And then I had to switch to Canadian pop lyrics because it was time to raise a little hell. And from now on, we need to be taking care of business in Canada too. So John Conley and a number of our veterinary colleagues from Guelph and myself got to speak to a Senate committee in winter of 2014. For us, that's February. And the bottom line was that despite the WHO call for a national strategy, Canada had none. And we were really calling for it and a number of things to be included in it. Now, I think the federal government was actually ready to move. They were thinking about it. And so it wasn't long before there actually was a federal framework declared in February of 2014 and an action plan in 2015. And we thought this was pretty late, but the nice thing is it is an all-of-government model, so the agriculture ministries, the health, all that sort of thing are playing, and like you, takes a One Health approach. So we figure the polar bear is going to be a little bit more formidable with firm footing, and the croc would have to watch it on the snow. Anyway, so the action plan includes all of the things that you'd normally include. And so if you take a look at it from 35,000 feet, they talk about a focus on surveillance of AMU and and of resistance, a focus on stewardship in all sorts of levels, and a focus on innovation. And what's not shown in this slide provided by the Public Health Agency is that there's just as much effort going on with agricultural regulation. It's almost its own area, and I'll tell you about that. So in surveillance then, happy to report that the federal report came out with an integrated Canadian antimicrobial resistance surveillance system report. Now it's still got gaps, but for the first time, everything that the feds have is in one place, similar to your ORA report, but with different strengths and weaknesses along the way. Community trends in resistance. We piloted a model that shows the feds how to do it. It's still not part of their regular reporting, but it's come along. There's been agreement on the priority organisms for surveillance, and we had a commitment to finding out what was going on with Indigenous Canadians, and thankfully there's nothing too awry going on with their use compared to anybody else's. And we've begun a process of identifying surveillance requirements for agriculture. So, like I mentioned, we have a Canadian nosocomial infection surveillance program that's been on for a long time, and they have good long-term data on utilization and on C. diff infection and that kind of thing. We've had a bit of a decline in C. diff rates since the worst of the Quebec outbreaks in the early 2000s. Here are rates of CRE. The rates of organisms that actually produce carbapenemase are about half of these. But they're very homogeneous across the country. Here's this thing popping up again. Do I have control over that? Do you have a chance just to minimize that?
We do, but then it's going to be left out, unfortunately.
Okay, I'll use this. Okay, that's fine. We'll go. Oh, I'm going backwards now. So we've also got data on gross utilization, and I was speaking to your veterinary folks yesterday, and they're saying, so far it's just gross mass. Our agriculture people tried to normalize things for numbers of animals and weight, but it really makes the curve look more or less the same. And so far, we don't have information by sector, by pork, by cattle, etc., what's in use. So if you line us up against European countries, we're not doing exceptionally well. We're between Germany and Belgium, up near the top end of the range. There's a lot of countries using a lot less in the way of antibiotics in agriculture. We got preliminary data on hospital sales, and you'll notice some discrepancies. So I mentioned Ontario was doing better with hospital stewardship, and maybe it's beginning to show up here. But these are crude data on hospital sales. These are defined daily doses per discharge. And it's important to note that in some provinces, the outpatient IV antibiotic therapy is covered by hospital budgets and included in these numbers, and in others it is not. So there needs to be a lot of tidying up those data before we move along. We put a lot of effort into getting people together on stewardship, and you don't want to know about how many people were in a room to talk about it. But the important difference now is that we've got the accreditation authorities on side, which has been the important difference in Australia as well. When something's measured, something gets done. And so accreditation is now online for hospitals, and also the organization Healthcare Can, which is really all the high power health execs that run all the budgets around the country. And these guys are good because they can go to lunch with the federal minister of health, ask for $40 million and get it, and they're very much on side with this sort of approach. There were a lot of actions that were put together under the stewardship plan, and I'm not going to go over them in detail, but I wanted to point out to you that we are focusing a lot on community here. We want to incent community prescription and provide feedback mechanisms in terms of good stewardship in the community. We want to develop national guidelines. You've had therapeutic guidelines since '78. We've never reached agreement across the Federation on how to do that, but we want to push things along. So we've got lots of good regional guidelines. And we're also very interested in a network of centers of excellence in knowledge mobilization here, which is one reason why we're here at NCAS, because you're one of the first national groups that's focusing on that. So I wanted to tell you a little bit about the veterinary world. By the end of 2017, growth promotion claims will be removed from antibiotics. I'd like to say this was a Canadian initiative, but we're in a common market with the US, and the FDA moved first. So the bottom line is that's happening anyway. You've also had control of prescription for important antibiotics for quite some time in Australia. That's coming online by the end of 2017 in Canada as well. Now, these things could be semantic victories. People might stop using antibiotics for growth promotion and start using them for other reasons, but at least those reasons need to be enunciated, and we can measure things a little bit better. We've also had an interesting problem. You're an island nation, but you're still importing a lot of different things. But if I'm a Canadian producer, I can drive my truck over the border to the US, load it up with antimicrobials, and tell the customs agent on the way back in, I'm using it on my own property. And there's actually a loophole called an own use provision that would allow you to do that. That loophole is going to be closed eventually. And that's important because otherwise we can't really measure how much is being used. And of course, this group wants to work on additional tools for animal health, other ways for animals to grow without antibiotics, and help with surveillance. And like you, I'm interested in how remote stations in Australia have done with the prescription requirement for antibiotics, whether it's all been done by telehealth of some sort, or because we have exactly the same problem, and it's one of the biggest obstacles to moving to a prescription-only model. Then on innovation, our research institutes are focusing on the main areas that have been identified by WHO: infection prevention and control, including vaccines, diagnostics, antibiotics and alternatives, and improvements in animal production. And we're hoping that there's more international partnership in this area. There's been a recent call that we're responding to where there's a considerable amount of funds put together in Canada in partnership with the UK and a number of other countries, unfortunately not Australia in this particular competition. On the top right there is Jen Gardy, a colleague of mine. She's a genomic epidemiologist. She's working with our TB people and a group at Oxford and a number of other centers around the world, and the focus there is whole genome sequencing for TB with the idea of early prediction of resistance profile of the isolates, so you get more accurate therapy early and more granularity when sorting out your outbreaks. And Natalie Stranadka, lower down, has been involved in a Canadian team that's identified an aspergillus-derived protein that inhibits carbapentamases, restoring their use. And I understand from the ID seminar the other day that there's some considerable interest in using peptides, cationic peptides, I think, in the same mission, the idea of restoring antibiotic function. So investment, of course, has been uneven. This is the Canadian Institutes for Health Research, our NHMRC, and most of it's been in innovation, which is perhaps perfectly reasonable, but I think anybody could say there's room for growth with stewardship methodology and surveillance in that funding. So I'm going to pause here and tell you a little bit about the program of community stewardship that's happened in Western Canada. My service institution is the British Columbia Centre for Disease Control. It is an academically linked institution with responsibility for public health province-wide in BC, big focus on communicable disease, and it has a counterpart in Alberta Health Services in Edmonton. And the linkage is my colleague Edith Blondale-Hill. So to explain my linkage with BC-CDC, I was playing around mostly with STI and HIV in the 90s. I was technically the guy responsible for sexually transmitted diseases in British Columbia. That was a very good thing. And then in the 2000s, I ran the epidemiology unit. We dealt with the SARS and the pandemic flu and that kind of thing. But it became very clear that we needed more action on antibiotic resistance, and we wanted to adopt a stewardship program in the community. And rather than reinventing the wheel, my colleague Edith had recently moved from Alberta, where she'd originated a program in the north, and we looked at adopting elements of that in British Columbia. So the program that I'll describe really touches on most of the WHO recommended approaches. We talk about providing timely ongoing surveillance for the jurisdiction, reducing unnecessary antibiotic use in people and animals. And our initial focus has been the community, but we definitely need to broaden it. And alongside my hospital colleagues who are working on stewardship in the facilities. And we wanted also to focus on community hygiene as a corollary of hospital infection control. What the program doesn't do is directly incent production of new antibiotics. So the program is known as Do Bugs Need Drugs? You can tell it was invented in the 90s because the color palette here looks like a 90s interior decoration scheme to a certain extent. And it began with education of physicians and other prescribers. So that takes the place, obviously, of continuing health education sessions. And we get regularly invited to sessions that cover a very high proportion of our GPs in BC. But it also includes a therapeutic guidelines approach similar to yours, which we use across Alberta and BC. And I'll tell you a little bit more about that. We've necessarily had to expand it to other prescribers, and I'm going to tell you why the dentists were so very important in recent years as well. But you'll notice we also try to indoctrinate post-secondary health science students of all sorts. And it's not just by giving them the education and giving them the therapeutic guidelines, but they are in fact the workforce. So 300 medical students and a whole smack of nursing students are the workforce that go out and visit schools and daycares and provide the community education around the key messaging around the program. So that's been a multiplier for us, and it's been a lot of fun. And finally, we've had a media presence that began with typical TV and radio and has necessarily moved more into the social media scheme in recent years along the way. So I'll show you a few things about that. We have a logic model for those of you that do program organization. Don't look at this, people, because it's not the sort of thing you want to do here, but I'll share this with anybody who wants to see it. And one of the reasons I'm here is the bottom right-hand box. We're really trying to think of ways to measure morbidity from antimicrobial resistance a little bit better than we currently do. The messages to the public are the simple, straightforward ones, that antibiotics are a precious resource. We all need to use them wisely. The usual stuff about what a viral infection is and how they're not helped by antibiotics, translated into cold and flus for the most part, don't require antibiotics. And hand washing and other elements of community hygiene. If you go to the website for Antibiotic Wise, which is the link to the commercials, you can go down a list and it gives you clues as to whether you really should be asking your doc for an antibiotic for some common garden syndromes. You can take quizzes, you can take a look at the movies, and you can see other materials, and there's referral to more in-depth material for professionals. Now, this Bugs and Drugs Guide, similar to your therapeutic guidelines, produced by an expert group and then vetted among a much larger group of professionals. There's no industry involvement in this one either, and it started off as a book, migrated through an iPhone app, and now we're arguing with ourselves about just open online access. In other words, we're asking the question, is the subscription model an obstacle to private physicians coming on board with this? The book, as your guidelines would, emphasizes first-line agents, but also there's a fair amount of emphasis on symptomatic treatment for things like acute bronchitis and otitis media, the most evidence-based symptomatic treatment when you're not using antibiotics. And we reinforce it with regular journal spots and continuing education. So what I can tell you in broad strokes administratively about the program is that since we started, the rate of prescribing per capita is down 15% in British Columbia. That translates in 2014 compared to 2005 to everybody. That's individuals and government spending 53 million less on antibiotics in the community, and to government saving about 25 million in reimbursements and that sort of thing. So it's not hard to argue a bit of cost effectiveness to government, even if they don't like everything else. But any of you who are scientists and time series and anything else will know, what do we still need to know? We actually need to know which of our actions are resulting in any change, or whether we're just dealing with secular trend and that kind of thing. In other words, experiment trials are important, and that's another reason I'm here visiting some of our colleagues further north in the country who've been doing some trials of interventions. I want to tell you a little bit about the surveillance we put together, because it's different than the national one. We have a pharmaceutical database that captures all outpatient prescriptions in British Columbia. So we get fed 2.5 million or so antibiotic prescription as line list every year. We don't have unique identifiers on that, but we're able to do the epidemiological breakdowns by person, place, and time. We've got age information, geographic information, that kind of thing. And there's some variables in there that allow us to know the college that the prescriber belongs to, so what profession is responsible. And another variable that tells us if it's an aged care facility, for example, where the prescription is taking place. So instead of a PDF report this year, we went through a project where we basically got the data sitting on a server, which is topped by a Tableau display. You can land here and you can look at an overall trend in antibiotic use. And below that, you can look at age and gender-specific rates of use, which are kind of important because use, of course, is not symmetrical across the age span. You can break down the use by which antibiotics are biggest. The biggest bubbles are the biggest ones in use for a given display. Or we can break things down through data linkage with billing codes that talk about indications to skin and soft tissue, respiratory, that sort of thing. So bottom line is I could create, the person can go in and look at this trend for any specific antibiotic, any class of antibiotic, overall use, or for select indications. With resistance, it was trickier for a long time, and then something strange happened in BC. All of our community labs consolidated in a monopoly, virtually, meaning about 80% of outpatient cultures and sensitivity data are in the hands of one lab information system. And we were able to get together with Life Labs BC and create a similar sort of landing pad that looks a little bit like an antibiogram. Each of these dots would speak to the level of susceptibility. The X's would talk about intrinsic resistance. And if you clicked on one of those dots, then you'd get a trend for a given bug-drug combination over time and a breakdown by age. And both of these landing pads also have a second page that has geographic breakdown on them, so you're able to sort by geography. So in simple terms, when I'm talking to the ministry anyway, I can say we did what we said we would do for upper respiratory infections. The rate of prescribing for acute bronchitis and for otitis media is down about 30% since we initiated the program. We had a problem that you didn't have because you got off the ground with controlling fluoroquinolones very early compared to most places, but we had a big increase in their use in the 2000s, accompanied by a big increase in fluoroquinolone resistance in Enterobacteriaceae as well, along the same line. That has finally reversed, and most of that, of course, as you can imagine, was ciprofloxacin, but there's a little bit of moxie use here by an unadvised listing of that drug as part of our formulary. Similar declines in new macrolides. But the thing that's really interesting for those taking a look at this is the gains have not been symmetrical across the lifespan. The pediatricians and GPs working with kids have done a much better job of sticking to new guidelines. So these are age stratified rates of prescribing, and the younger you are, the faster it's fallen for the most part. So a lot of the gains have been with little kids. And then, we had an interesting argument in the infectious disease thing as to whether this actually represents improvement. But this is prescribing, indication-specific prescribing for UTI. And you can see that I consider turning the corner on fluoroquinolone use an improvement. The decline in cotrimoxazole use I'm considering an improvement too, because we've had cotrimoxazole resistance rates among E. coli in urine, for example, of about 25%. So it's not an advisedly first-line drug in our setting. And here's been the big increases in nitrofurantoin use. And Kirsty and I were talking about this before I came in, and so I will pledge to go back home, link this with morbidity data, and show you that we're not killing British Columbians in droves by using nitrofurantoin. But it is a drug that has a few advantages. There's fairly good susceptibility for treating simple cystitis. It's not a class of drugs we're using to treat any desperately ill person in the hospital, so we're not as worried about selection to it, etc. along the way. And down at the bottom here, you see increasing use of cefixime, amoxiclav combinations, and that's being driven by increasing prevalence of ESBL. But we're going to need to pick up the fight. So we can say, okay, we've moved in the right direction, especially with upper respiratory infections. Gram-positive resistance doesn't look too bad. And when Canadians are looking to pick up the fight, sometimes we turn to Canadian icons. Captain Kirk, of course, William Shatner, is a Canadian, and he came out to remind us of that. And so whether you're grappling with an alien reptile or another kind of problem, Bill Shatner can still be relied on, and we're bringing him out of the woodwork to fight a couple of new fights with antibiotic resistance. First of all is what I describe as the worst news for the image of dentistry since Little Shop of Horrors. So if any of you are into the musical comedies, you'll remember that the villain in Little Shop of Horrors was Orin, a dentist, played by Steve Martin, and he'd ride, dressed in leathers and drive around on a motorcycle. Sadistic dentist, basically, who met his doom at the hands of a carnivorous plant in the end. And then perhaps the more sinister depiction of dentists was Marathon Man along the way. But why we talk about that is that while family physicians, physicians in general, had decreased their rate of prescribing 25% between 1996 and 2014, the rate of prescribing by dentists increased 62%. This is rate per capita, per population, along the way. Now, most of it is simple penicillins, but some of it's clindamycin, which is a drug that you're going to worry about along the way. That means that dentists have gone from being responsible for 6.7% of prescriptions to 11.3% of prescriptions in that time span. They've become important. So we went online with the Canadian Dental Association, did some webinar, asked around, and the dentists identify, well, there's still a lot of antibiotic treatment for surgically treatable conditions like periapical abscess and irreversible pulpitis. They identify that dental implants, where there actually is justification for using perioperative prophylaxis to reduce implant failure, are driving a lot of use, but when I speak to my dental colleagues, they're often prescribing a full week of prophylaxis, not a 24-hour or less program. They talk about slow uptake of guidelines around prosthetic joints and valvular heart disease, where in recent years we've drawn way back on prescribing. They talk about underinsurance, meaning that if it's too costly to do a surgical procedure on an uninsured person, sometimes a cheap antibiotic prescription seems like something that somebody wants to try. They've accused it of being a problem with the aging population, but we've since proven that age-stratified rates of use in dentistry have gone up. So it's not just demography. And there are more dental registrants, and you'd say, well, how should that drive population demand? Most of these prescriptions are related to procedures, and so you have more surgeons around, you may well have more procedures. So what we've done is we published the story. It was on the cover issue of the Journal of the American Dental Association. We've created free for credit dental CHE in Alberta and BC that's available. Andrew Morris, our colleague in Ontario, and others worked with the orthopedists and with the dentists and came out with a consensus statement basically nixing most use around prosthetic joints. And that's good because the orthopedists had been ambivalent and that had confused the dentists. We've created materials for dentist's office, and we're doing some further detailed survey work with the CDA and University of Toronto. We can also break down our data in different ways. We can talk about, percent of prescriptions. Docs are still responsible for about 87%, dentists at 11.5% or so, depending on which sort of measure you're using. And there are other groups prescribing. But you can take a look at defined daily doses per prescription, which you could say for most professions ranges between 8 and 10.5 and is a bit long. It's long for dentists who should probably be prescribing mostly perioperative prophylaxis. It's long for docs because a lot of our courses of treatment should be shorter. So we can work on that. And then being on the west coast of a country, I don't know if it's like this for WA, we're sometimes a bit flighty, and somebody thought it was a good idea to allow naturopathic physicians to prescribe. They don't prescribe a lot, but when they do, they prescribe 3 times the defined daily doses per prescription, and that's because of a lot of confusion around how to diagnose Lyme disease and other things. Any demographers or somebody who studied demography in the audience? We spend a lot of time comparing things between European countries and other countries in terms of prescriptions or defined daily doses and that kind of thing. And it's interesting to think that maybe demography does matter. Our national folks were creating statistics showing in this red line that defined daily doses per prescription was climbing, actually considerably in Canada over a 15-year span. And the concern there was, does that mean that prescribers are losing their mind, losing their discipline, and that kind of thing? And yet we'd had this observation about children being prescribed a lot less. And of course, as you know, children have a lot fewer defined daily doses per prescription. So all it's to say is when you age adjust that, there's been no difference in defined daily doses per prescription at all. So just a reminder that demographers are important, and when we're making comparisons over time and space, we may need to think about demography. So the other area of concerns, dentists was one. The other area of concern is, of course, one that's a growing one for you, and that's the problem of UTI, gram-negatives with simple monoresistance, and of course, ESBLs right up to CPOs. And the first observation that we'd have from the administrative data is that the rate of UTI treatment adjusted for population is actually increasing. So while things are going down for skin and soft tissue infection and for respiratory infection, we've actually got an increase here, most of it coinciding with an increase in treatment for simple cystitis along the way. We can also show in other analyses that this often means that people with a single episode of UTI are getting more than 1 dose of antimicrobials, something you might expect to happen if you've used an antibiotic that didn't work the first time, if you've got more of a problem with susceptibility. And for those of you who are critics of nitrofurantoin, it's fair enough to ask, well, could that be the problem because it's less cidal than some of the other antibiotics that we might use for UTI? We've also determined our rate of use in long-term care facilities is very high. Actually, I think your aged care use may even be a little bit higher than this, but it's enough to make us say, okay, what's going on in long-term care facilities that might be changeable? And that's important. I mentioned that we like to take an epidemiologic approach to microbiologic data, and that is you break things down by age, by geography, by person, place, and time. And when you do that with fluoroquinolone resistance in E. coli, for example, you can see that while we may have an overall rate of fluoroquinolone resistance of 25% in our urinary isolates of E. coli, it's not really a big problem around young women who might be getting honeymoon cystitis or something, but it gets to be the majority of isolates in the elderly. Extreme elderly. So that's where the action is, the elderly. And then looking south of the border, we've been concerned by the fact that some long-term care facilities in the U.S. Have been the nidus of KPC, which is spread to hospitals. So we've had various different campaigns. This is a national one by the Association for Medical Microbiology and Infectious Disease. We've had the academic detailers go in, and this is symptom-free P, let it be. Basically, stop using antibiotics for asymptomatic bacteriuria. Wait if you think somebody's got a UTI that's causing their mental status problem, to rehydrate them and reassort things. And then when you do have symptoms that are localizing to UTI, go ahead and make that microbiology assessment. We've also done a little bit of work with trying to say, how can we summarize all this stuff with bug-drug combinations into something that's actually meaningful for people over time? And with Andrew Morris and others in Ontario, we've done various different models of indices that might be useful for tracking what's going on in hospitals. And we've adapted this CDC-based model from Laxminarian First of all, you can use it to come up with a drug resistance index on E. coli. It's sort of like a Dow Jones Industrial Average, where you're basically trying to predict what's the probability that you'll have a bug-drug mismatch with standard empirical treatment. And that's constructed by taking the rate of resistance to a drug class at any given time, weighting that by the proportional rate of use of that drug class, and then summarizing across drug classes. So you can come up with a resistance index for an organism like E. coli, for example. And when you do that, it's actually kind of instructive because you can do it two different ways. You can do it the static way, this blue line, where you can see that the resistance index would be going up, meaning more problems if physicians weren't adapting their prescribing. But in fact, they do adapt. And when physicians adapt, and in our case that means less fluoroquinolone and more nitrofurantoin use, they've held the line on the drug resistance index in UTI. This is a short period of time, and we'd want to follow it along a little bit more. But it's interesting. And of course, with UTI, you can easily envision saying, okay, let's take the organism-specific indices, which is, the first two terms here, but let's sum across the universe of organisms that causes UTIs, because we have the same information on each, and with a proportionate weighting for the organism. So we're currently doing that work. But I wanted just to spar off discussion at this point, and what we're really interested in doing. Got a little background noise there from somebody online, maybe? What we're really interested in doing is hybridizing ideas. This is a moosaroo or kangaroos or something like that. Maybe not a wise evolutionary direction necessarily, but the things we have in common is that we're pushing for either a network or a single center for excellence in stewardship. So it's been great to tour your NCAS model, newly minted. We're supplementing our administrative data with surveys. We're looking at doing that. So while we have great population coverage on antibiotic use, we have nothing like what you've got with NAPS on appropriateness. And appropriateness is really the fundamental question, not amount of use. We're looking to raise the bar on surveillance, so we'll be comparing notes with John Turnage and others at Aura, and of course a lot of the information from here is going into that report. And like I mentioned, it's important not just to lay out programs and watch what happens, but it's important experimentally or quasi-experimentally to understand what works. And so we're interested in designing more intervention research so that we can be clearer about what interventions are making a difference in our environment. So with that, I'd like to stop and open some discussion. Kirsty, I'll repeat your question for the people online, right?
David, thanks for the talk. It was really great. I was looking at your online displays of antibiotic susceptibility for particular organisms,
yeah.
and I've had discussions with GPs where they say they really love that. They love to be able to go to a website and look up in a urine isolate what's the percent susceptibility of E. coli. One of the reservations we've had with making antibiograms broadly available is we think that the sampling is not necessarily reflective of the population, in that when you talk to GPs, many of them will tell us that they will, if a person comes in with symptoms of cystitis, they'll give them trimethoprim, and only then, if they fail and represent, they'll send a urine specimen off. And for that reason, there's been some concern that the samples that reach the laboratory may be biased, that they may not be truly representing the pathogens that are initially presenting with cystitis. And so we've held back antibiograms from general prescribers and just given it to expert prescribers who write guidelines, etc. But I'm interested in your experience of GPs getting that information, whether you've had any concerns about that.
So for those of you online, Professor Busing is asking basically about whether there could be a downside to making antibiograms available to GPs, because they may not reflect the primary isolates that people have, and they could lead to inappropriate prescribing along the way. And my answer to that is I actually share that. The reason for these tools is largely the production of epidemiological trends, and the users of the tools so far have been mostly microbiology, infectious disease, epidemiology, our colleagues in microbiology and immunology who are tracking the science of resistance over time. our labs are very careful to report the primary method of communicating with GPs is the lab report, where there's really an emphasis on not putting too long a list of antimicrobials on it, making sure that the advice is there. And yet there are some labs that are continuing to produce static antibiograms. I see this as more a tool of trend tracking, not a tool for the family doc in terms of prescribing. I think that's where the guidelines come in. Is there a mechanism to get questions from anybody online?
Yeah.
And what is that mechanism? Oh, it's with you. Okay.
So, David, I'm interested to hear about what you've been able to get out of administrative databases for the community, because that's the issue that has been the big black hole for us.
Mm-hmm.
We've had a bit of a chat about it, but perhaps for the audience, some of the challenges that you face.
Yeah, so the challenge with administrative data is going to be the same here as in Canada, where there's a lot of information on protection of privacy and everything else. So we have not received at the British Columbia Centre for Disease Control any identifying data. The protections that we put in place on the privacy thing has been that you basically got scrambled PHN, public personal identifiers, scrambled physician codes, so that you can sort of tell that you've got a doctor or a patient doing something, but you haven't got any idea who they are. So that's good. So we've only got those things. The actual matching of the billing, which allows us to talk about indication, with the prescription, which allows us to talk about the drug, is done at the ministry level and then handed over to us. We also have agreements. So when you take a look at those particular displays we have up there, the underlying line listed data don't sit on the server. There's sort of an aggregated Excel sheet that sits under and informs the graphs. And we suppress any cell sizes that would be potentially re-identifying, from one person of a given age group from a really small community. So we've got rules that we apply to what we publish along those lines. The bottom line, though, is that we've been tracking the drug prescriptions since about 2000. We have a very good relationship with the ministry around it because they like to see the reports. They like to see which way things are going. They are, in fact, funding our program, and so it's useful for them to know what's actually changing as a result. So when you've mentioned that it's been difficult to get similar data out of government here in Australia, I wonder if that's an absolute no, or just a data steward that's very concerned about privacy, and maybe that can be overcome. Yes.
You touched on microbial resistance in Indigenous populations, so quite high rates of things like CA, MRSA, and high rates of skin infections, like respiratory tract infections, which has driven antibiotic use. So I'm interested in your thoughts on your experience with Canadian Indigenous populations.
Yeah, well, I was surprised in the federal report, which is the first one that broke things down around Indigenous use. Okay, to repeat the question is what's the Canadian experience been with Indigenous populations, and the concern has been here in Australia that there've been some asymmetry in the indicators of illness and so forth with regard to infections. So in Canada, you've got a very, very diverse Indigenous population, some of it highly integrated, some of it not, some of it fairly far along in getting over the colonialization effect. So the federal data that we saw as an appendix to its first report was the very first we saw comparing use in Indigenous Canadians with others. And things tracked fairly closely, so there wasn't anything big there. But in terms of health indicators from infections, it'll depend very much on which group of Indigenous people and what goes on. We certainly used to have a bigger problem with respiratory infections. Tuberculosis rates would be higher. They're now converging a little bit more with the general population, but whenever you have a settlement where you've got poor housing, lots of people crowded into one place, poor ventilation, you've got higher TB rates. It's almost a socially determined risk there. We also had higher rates of things like pneumococcal disease in the past, but that's been converging a little better with the pneumococcal conjugate immunization moving along. And then in terms of skin and soft tissue infections, yeah, you do have a subset of Indigenous people who are overrepresented among street-involved people in urban Vancouver, for example, and that's where you tend to see more in the way of the CA-MRSA sorts of things along the way. That's not necessarily reflected too much in prescription, because a lot of the CA-MRSA is managed topically or by incision and drainage in community clinics.
David, my other question is this federation that you face like we do, in that many of the states are at different stages, and it's been always an interesting thing in Australia to pull everyone together. And I think the NAPS has been a great success in that we've been able to cut across all that just through sheer, I guess, accessibility and working with all our colleagues. How are you going in Canada?
How we're going in Canada, the question is, you know, comparing how it is as a federation trying to pull things together and get things going. As a federation, I think sometimes our provinces stand on their own individuality even more than your states do from time to time. So sometimes it's been relatively difficult to do that. But we're interested in NAPS because the Public Health Agency of Canada is interested in NAPS. Because I think it turns things the right way around. What you've built into NAPS is a set of reporting tools that the facilities really kind of need. Accreditation is happening. If you provide them with the parameters they require to give to accreditors along the way, and then you're really incentivizing the uptake of something. It's not just somebody else asking for more information that might go into a report and make you look bad. So I think you've done that the right way around by making it of value to the end user first, and then it becomes possible to roll things up. And as you know, people at Public Health Agency of Canada are interested in a model like that for the country. In terms of the other data that we've got nationally, it was really the best data are the data that were already assembled by other groups. So the nosocomial infection surveillance group was a group of collaborating, mostly academic hospitals around the country. Those data have always been available, but they don't necessarily represent the full spectrum of hospitals. The antimicrobial use data were already assembled by IMS Health, which is a private sector health information firm, and they were just adapted and interpreted by the Public Health Agency of Canada. But appropriateness, that's where we all need to go. And I think the hospital NAPS, it will be interesting to pilot. And we're beginning to talk with vets and primary care docs about whether there's any equivalent in those particular domains. Before wrapping up, I got something I'd like.
So thanks everyone. Any more questions before we wrap up? No?
Okay, before you go, I wanted to tell Kaz and the whole group at NCAS how much I appreciated the visit. So 2 things our countries share. I mean, one very important thing is we've got these small, relatively small populations, vast open spaces. Yours because it's too hot, ours because it's too cold a lot of the time. But those landscapes are sometimes unimaginable to people who haven't been there, and they're part of the essence of who we are. So my favorite Canadian landscape artist was Lawrence Harris. And he did sort of abstract interpretation of landscapes. This is a print of North Shore of Lake Superior, done in 1926. It just gives you an idea about the light and the space and everything else that you get in what you might otherwise consider to be barren country, like your outback, right? Along the way. So I'm giving this to Kaz for the whole NCAS group, basically with thanks for what has already been a productive visit, and I hope we continue to see that over the rest of the week.
Thank you very much, David.
1926, this guy, Lawrence Harris. Yeah. You must have a wall somewhere.
No, we do.
That was great. I'll see you later on, David.
Yep.
What time are you guys doing?
1 o'clock.
we're going to fight. Okay, go.